this should be the final segment that we record for this chapter. So we're going to talk about marijuana. Marijuana is very prevalent among young adults and easily crosses the placenta and remains in the body for up to 90 days. It affects neurotransmitters and brain chemistry in the developing fetus, results in shortened gestation and higher incidence of IUGR. And the thing with marijuana is you have to worry about the compounding issue in multi-drug use, meaning if a mother uses marijuana, she's more than likely using other illicit drugs also. Cocaine is the cocaine we know is the number one cause of placental abruption. So if you want to go back to several chapters where we talked about the complications of labor and birth and the signs and symptoms of placental abruption, if a patient presents with those signs and symptoms of placental abruption, one of the first things you'll do is ask mom about drug use, and she will usually receive a drug screen. Neonates do not experience withdrawal, but rather show neurotoxic effects of the drug, so they don't necessarily have NAS type syndrome. Risk factors for the babies of moms that use cocaine include perinatal morbidity, IUGR, low birth rate, and preterm birth. And if you look on page 872 in your book, box 35-1 shows the fetal effects of cocaine use. Next are methamphetamines, and there's limited data, although higher incidence of placental abruption, preterm birth, and IUGR are noted. Signs and symptoms include, for the baby, include decreased arousal, increased stress, and alterations in movement, poor feeding, and poor weight gain. So that's what you need to know about methamphetamines. And the final drug is MDMA for ecstasy. It's toxic to nerve cells containing serotonin, causing long-term damage. Ecstasy is a synthetic psychoactive drug that causes hallucinations and stimulant properties. It alters the body's temperature regulatory abilities and can cause a sharp increase in temperature. Risk factors to the baby include congenital anomalies and long-term learning and memory problems. Here's a picture of a baby with fetal alcohol syndrome on the left. And again, I know I slaughtered those words when I was describing them, but be sure and go back and look and read that part in your book and compare it to this baby, and then it helps having that visual along with the description to help it make sense. And on the right is an NAS scoring sheet, and if you look on page 874 in your book, there's a larger version of that. You do not need to memorize that. You may have used this in your clinical setting or seen this in your clinical setting or at COSAIRS. Just note that, of course, the higher the number, the more abstinence withdrawal symptoms that the baby is exhibiting. So, but again, you don't have to memorize that. It would be important that you are familiar with the signs and symptoms of NAS and not necessarily how many points it is. Okay, other drugs of concern that we don't always consider a drug that can cause concerns. Caffeine, ACOG and Marchidines recommend that caffeine intake in pregnant women should not exceed 200 milligrams per day. And we've covered caffeine in other chapters, so we're just going to leave it at that. And next are SSRIs, and this is a little bit newer, realizing that a lot of the even prescriptive drugs that mom takes for any type of mental disorders can actually affect the baby, and they can exhibit some NAS symptoms. And so, you use them with caution just like anything else. So the use should be determined by a risk-benefit analysis of the risk of the fetus and neonate with the use of medication weighted against the risk of not treating the mother's psychiatric condition. For instance, if mom has severe depression, then you have to rule out the risk of the baby may have some NAS symptoms, but is that safer than a mom that's depressed and possibly psychotic or thinking suicide, that type thing? So it's a risk-benefit analysis of the risk to the baby compared to the risk of not treating the mother. All SSRIs cross the placenta and are transferred to the breast milk. The mom should be on the lowest dose possible that is effective for her. So, you take some of your common SSRIs where they have a small, a moderate, and a high dose. If the mom is controlled at the lowest dose, then leave her at the lowest dose. There's a possible increase in cardiovascular defects with the use of SSRIs, but especially with Paxil. If they are used during the second trimester, it's shown preterm birth and low birth weight, and use during the third trimester has shown NAS symptoms. They are usually mild and last no longer than 2 days. So when you think of a baby having NAS symptoms withdrawing for 2 days, that's a small risk compared to a psychiatric condition for the mother. This slide talks about nursing care that's really applies to all of the drugs that we've discussed. So most often the nurse is the first to notice neonatal behavior for NAS. So I always say that newborn nursery nurses have such a level of assessment skills, and they know when something is wrong, as opposed to when the baby's in the NICU, we know those infants are sick and on monitors. So the assessment skills for newborn nursery nurses are just awesome. Urine and meconium screening can be done to identify substances that the mother has abused. Care can definitely present a challenge. Nursing care includes fluid and electrolyte balance, nutrition, infection control, and respiratory care. Some of the things that is therapeutic include swaddling, holding, reducing the stimuli, can help ease withdrawal symptoms. If you look on page 876 in your book, box 35-2 has care of the NAS infant. Some of the drugs that can be used if needed include neonatal tincture of opium, phenobarbital, or paregoric. The administration of Narcan, really to both the mother and the infant, of course this chapter is talking about the baby, is contraindicated because you put them into immediate withdrawal. So Narcan is contraindicated. Drug dependence in the neonate is physiologic, not psychologic, and that's a positive. And so what that means is in adults, we crave it. It's psychologic. We're looking for our next hit. We've got the physical symptoms, but we also have the mental symptoms that go along with it and that need. And with babies, they are, of course, more likely or higher risk down the road of using drugs, and that could be from how they're raised. They're raised around drugs, but it does affect, their brain. But with the babies, we treat the physical symptoms. And just know that these mothers require considerable support. I mean, how sad would it be to be addicted to any of these drugs? And it's not that you're choosing the drugs over the health of your baby, because it is a dependence issue. I mean, but how sad and how much support these mothers need. I mean, these mothers are not out to do something to harm their baby. They just have a disease process and an addiction that they can't, that overrides their ability to take care of themselves. So, There's a lot in the media about this, and it's very sad, but we just have to realize that this is a disease process for the mother, and that they want nothing more than a healthy baby, and they want nothing more than to do what needs to be done to take care of the babies. But due to the psychologic involvement and, just the habits and poor choices that they have made, it does affect their parenting abilities. So again, just it's really hard. Just try not to be judgmental. Try to be supportive. Breastfeeding is a difficult issue, and so although we know breast milk remains the optimal source of nutrition for these infants, care must be taken to avoid exposing the infant to additional drugs through breast milk. And you just have to dig a little bit deeper into what drug they're using and what support that they have to continue breastfeeding, and the risk-benefit analysis. So here are your key points. And the last thing we'll do is go over the practice question. So with regard to the classification of neonatal bacterial infections, nurses should be aware of which of the following. A. Congenital infection progresses slower than healthcare-acquired infection. B. Healthcare-associated infection can be prevented by effective hand washing. Early onset infections cannot. C. Infections can occur about the same frequency in boy and girl infants, although female mortality is higher. And D. The clinical sign of a rapid high fever makes infections easier to diagnose in the neonate. So the correct answer is B. Hand washing is an effective preventative measure for late onset or healthcare-acquired infections, because these infections come from the infant's environment. Early onset or congenital infections are caused by the normal flora in the maternal vaginal tract. Congenital infections progress more rapidly than healthcare-acquired infections. So A is incorrect because congenital or early onset infections progress more rapidly than nosocomial or late onset infections. C is incorrect because infection occurs about twice as often in boys and results in higher mortality. And congenital infection progresses more rapidly than healthcare-associated infections. D is incorrect because clinical signs of neonatal infections are nonspecific and similar to non-infectious problems, making it difficult to diagnose, and congenital infections progress more rapidly than healthcare-acquired infections.